Hello, Assalamu alaikum. Everybody, I'm Dr. Naseer Ahmed Memon. Uh, I will be there every Thursday. Uh, there will be every week three consultant on lectures. My class will be every after every 2 weeks. Last week, Dr. Aziz Langa, then me, and then Dr. Amir Jamali will take. I will teach you the infectious diseases. We will deal with infectious disease like tetanus, poliomyelitis, typhoid, malaria, UTI, diphtheria, acute gastroenteritis. All we will discuss in every week, and in the last we will discuss the immunization vaccinations. So today we discuss on tetanus. It's a very important regarding the adult in the pediatrics. You know that tetanus is an acute spasmodic paralytic illness caused by neurotoxin produced by Clostridium tetani. So it is the acute spastic, like in the acute flaccid paralysis or poliomyelitis. You know the in definition there is the flaccid paralysis, but here there is an acute spastic paralysis illness caused by the neurotoxin produced by the Clostridium tetani. So what is the Clostridium tetani? It's a motile, gram-positive, spore-forming, obligate, anaerobic drumstick shape, whose natural habitat worldwide is the soil, dust, and the elementary tracts of the virus anywhere. So this look like the drumstick appearance. So what is the epidemiology of the tetanus? Endemic is 90 developing countries. You will find the tetanus. The most common form is the neonatal umbilical tetanus, kills approximately 5 lakh infants each year, with about 80% of deaths in just 12 tropical Asian African countries. 15,000 to 30,000 unimmunized women worldwide each year of the maternal death. So it's a very important preventable disease which have a high mortality. So what are causes of the tetanus? And there is a most is non-neutral case of tetanus associated with traumatic injury, penetrating wound, inflicted by the dirty objects such as nail, splinter fragments of glass, unsterilized intramuscular injections, animal bites, abscess, including dental abscess, ear, other body piercing, chronic skin ulceration, burns, compound fractures, frostbite, gangrene, intense surgery, and infected insect bite. These are the non-neonatal causes. You know, in the neonatal causes, one of the most common cause is that the umbilicus. Umbilicus is the source of neonatal transmission of the infection. When anybody who is apply the unsterilized blade and surma and any dirty like infected thread on that and not apply the cord. So anything that will apply the on the umbilicus, they transmit or increase the risk of the neonatal tetanus. So how the tetanus is happen and in the newborn or the adults or in the pediatric, what is the pathogenesis? When it is transmitted, there is a tetanus-spasmin, which is a zinc metalloprotease, is released in the wound and binds to the peripheral motor neuron terminal, enters the axon, and via retrograde intraneural transport reaches the nerve cell body in the brainstem and the spinal cord. What happened that the toxin migrates across the synapses to the presynaptic terminals, where it blocks the release of the inhibited neurotransmitter glycine and the GABA by cleaving protein crucial for the proper functioning of the synaptic vesicle release. So the function of the agonist and agonist is lost. What happened? It blocked the GABA and the glycine. GABA and glycine is the major inhibited neurotransmitter are particularly sensitive to the tetanus-spasmin, leading to the failure of inhibition of motor reflex response to the sensory stimulation. This results in the generalized contraction of agonist. So that body fix that it cannot move, or the flexion and extension function is the loss, and it remain in the tetanic spasm. It is due to the all inhibitories, that's the reflexes that command to the flexion or extension is due to by the glycine and the GABA. So that all is inhibited. There is 4 types of the tetanus. One is the generalized tetanus, another is the localized tetanus, and third is cephalic tetanus and neonatal tetanus. We know that 2 types is the common, that is the neonatal tetanus in the newborn, generalized tetanus we see in the adults, in the pediatric, but this is the very rare 2 types, localized tetanus and cephalic tetanus. So we will describe what is the generalized, what is the localized, what is the cephalic, and what is the neonatal tetanus. What is the generalized tetanus? The incubation period is 2 to 14 days, and in which what the features you will find is in the whole body. The triasmus. What is the triasmus? This is the masseter muscle spasm or lockjaw. Triasmus is the lockjaw in which there will be headache, restlessness, irritability, followed by stiffness, difficulty chewing, dysphagia, neck muscle spasms. All that facial muscles is involved and look like lockjaw, not able to open the mouth. And what is the what happened in rhizosis sardinus? That integrable spasm of facial buccal muscles. So that will be look like a fixed smile, giving when you see the child. That is the rhizosis sardinus. And third presentation is the apostolonus. Apostolonus kaman ki tarah, that body happen, apostolonus. Reflex spasm like, and then the laryngeal spasm. Laryngeal spasm is the a very bad complication that anything that child take and it is reach to the larynx and it lead to the laryngeal spasm and the death. And the last is the autonomic effect. Autonomic effects is a very serious complication that sometimes that will be tachycardia, dysarrhythmia, labile hypertension, diaphoresis, cutaneous vasoconstriction, and that high-grade fever temperature. It's all that due to the autoimmune effects. So look in the generalized tetanus, you have to see the lockjaw. Lockjaw look like this one, rhizosis sardinus, and this one a fixed smile. I said that, and the spasm like the opisthotonus. Then second presentation is the localized tetanus. When there is a results in the painful spasm of the muscle, adjust to the wound side, like it can be the hand, in the feet, and then followed by the generalized tetanus. So start maybe localized and later on can be the generalized. If it is a localized, it's a self-limiting and in the few weeks will be resolved. Then cephalic tetanus is one of the rare presentation form of the localized tetanus involving the bulbar musculature that occurs with the wounds or foreign body in the head, nostrils, face, and chronic otitis media. Cephalic tetanus is characterized by retracted eyelids, deviated gaze, triasmus, rhizosis sardinicus, and spasms of tongue and pharyngeal muscle. Here what happened that only the face involved, not the body. Child can move the hands, arms, legs, can walk, but only cephalic. They cannot open the mouth and look, and there will be rhizosis sardinus, triasmus, and but the child will be the conscious in the cephalic tetanus. Then last is the neonatal tetanus, tetanus neonatum. This is a very important in the pediatrics. You will come across, and it happened 3 to 12 days of the birth as a progressive difficulty in feeding, sucking, swallowing, and so with hunger and crying. Child will be crying, continuous crying, will be hungry, but unable to take orally, not able to open the mouth and not taking orally, not sucking, but only crying. Paralyzed and diminished movement and stiff rigidity to touch. When you touch the patient, then that will be stiffness and rigidity. So it can be with or without opisthotonus. So the diagnosis is that child not taking orally, newborn is conscious, and when you touch, it is the stiffness. And you check the sucking reflex, that the child not able to open the mouth and not able to suck, and it will be grip. How you diagnose? So in every disease there is an investigation, but the one of the disease tetanus is that where there is a diagnosis, the clinical. There is no investigation. Just you have seen the one case, Clinically, you have seen the one case, you diagnose the tetanus. In the newborn, at the adults, only just you have to see in the case, look like there is a lockjaw, and there is a fiximile, and on the touching, there is a stiffness, and the patient is conscious. Important is that in the tetanus, there will be no unconsciousness, no no lethargy, only the child will be conscious but unable to open the mouth and stiffness of the body. Then there is some differential diagnosis when the patient of the tetanus come there. Are you to see that you have to keep some different diagnosis? Not every child is tetanus, or the stiffness is the tetanus. So there will be like tetany, bacterial meningitis, encephalitis, rabies, abscess, buzz trauma, hypocalcemia can come for the look like a tetanus. Like in the hypocalcemia, you found the carpopody spasm, and birth trauma, birth history, like there is a seizures, so birth asphyxia. Then one out of these encephalitis, yes, you will found the patient have a unconscious and bacterial meningitis, but others, rabies, tetany, or abscess, like retropharyngeal abscess, when there is a abscess retropharyngeal, child unable to the open the mouth. So in the retropharyngeal abscess look like a cephalic tetanus. So these are the differential diagnoses when you have come across a patient. So you must keep the few differential diagnoses for making a one diagnosis. So, but the tetanus is the clinical diagnosis. These all others have must have to investigate to reach the diagnosis. So when you diagnose the case and you confirm, then there is a management, how you have to manage the child. And first of all, that tetanus patient should be admitted in the hospital, and there is no investigation. You are admitted, keep in isolation. What you have to do, the 3 steps, like remove the source of exotoxin, neutralize the remaining toxin, and provide supportive care. How you remove the source of the toxin? If there is a newborn, and then if this umbilicus is contaminated, dirty, like surma is there, or there is a thread, or that means bleeding or something, then you have to wash with the normal line. Or if there is a wound, dirty, any infected, then that should be clean, wound, and then neutralize remaining toxin by the antibody. You have to give the immunoglobulins, and then how you have to provide the supportive care. Supportive, yes, you keep the isolation patient and dark room, not touching, and keep in one patient in the one room. You have to provide the bowel and bladder care. So what are the specific measures? Like I said, that neutralize the exotoxin. By the, you have to give the neutralized by tetanus immunoglobulin after it reaches to the spinal cord. So what is the dose of tetanus immunoglobulin? The dose is that you must to give the 500 units of tetanus immunoglobulin intramuscularly. Okay, and there is a range of 3,000 and 3,000 to the 6,000. So it depends upon, if the newborn you have to give the 5,000, but if it is the older child, you can give the 3,000 units to the child. Second one, if it is the tetanus immunoglobulin not available, then you have to give the IVIG immunoglobulin. It contains the 4 to 90 unit per ml of the tetanus immunoglobulin. But if it is tetanus immunoglobulin is not available, then you have to use intravenous immunoglobulin. Then third choice is the ATS. This is the old, that previously when anti-tetanus globulin was not available, then we're using the anti-tetanus serum, because it can lead to the 15% serum sickness. It is the dose is 50,000 to 1 lakh unit, but you can give the 10,000 units. It is sufficient. But nowadays, ATS we are not using. Before it was used, but if the conditions are in hospitals where there is a ATG is not available, then you can use the ATS. Then antibiotics. Yes, there is a role of antibiotic, that remaining bacteria or exotoxin which is attached there, that is neutralized by the antibiotic, and which the exotoxin which is attached to the neurons and traverse, it will be remain there. It remain for the 2 to 4 weeks for the 6 weeks. But that toxin which is in the wounds, it can be neutralized by the killed by antibiotics. You have to give the penicillin is the drug of choice, 1 lakh unit per kg per day, divided 4 to 6 hourly IV for 10 to 14 days. Then second choice, if the penicillin is not available or if it is drug allergy, then you have to use the flagyl, metronidazole. Another option is the erythromycin, tetracycline. Out of these four, you have to give the any one antibiotic, either penicillin, either metronidazole, either erythromycin or tetracycline. Then important is that you have to neutralize that exotoxin. You have washed the wound. You have to give the tetanus immunoglobulin. Now important is that the toxins which is attached to the neurons, it will take 2 to 6 weeks to lose their effects. So for this patient, continuous spasm, continuous contraction of the body. So for this, you have to sedate the patient. For sedation, you have to use the diazepam 0.1 to 0.2 per kg every 3 to 6 hours, given intravenously, and it will be remain for 2 to 6 weeks, and then you have to taper. Other drug, you can use the phenobarbital. Okay. Then others option are magnesium sulfate, midazolam, chlorpromazine, dantrolene, and baclofen. Sometimes you have to use the phenytoin also. So these do not use all these drugs. First of all, you have to use the diazepam and phenobarbital, and second injection phenytoin. Okay, these are the three drugs that you have to use. Then if it is not effective or still patient have a not sedation, under sedation. So here you have to must understand there is a three words: under sedation, over sedation, and the sedation. Sedation is normal. You have to give the diazepam, phenobarbital. Patient is by the touching, there is a contraction. Otherwise, he is sleepy. Then it is a sedation. And what is the under sedation? Under sedation, that there is a still fits is there, contraction is there. Then you have to need it. Another anticonvulsant you have to aid. Third is the over sedation. Yes, you have to give the 3 to 4 anticonvulsants. The patient is on touching. There is no contraction. This is the very alarming situation. You have to decrease the sedation. This is that over sedation. So for this, you have to decrease the sedation, decrease the dose of the anticonvulsant. Then supportive care. This is very important. I said that you have to keep the patient in the place the patient in the quiet, dark room, protected from all necessary sound, sight, touch. You have to remove the crowd. Only single one attendant should be with the patient, not all that 4 attendants with the patient. So then clean the umbilicus. I already told you that there is a sometime surma or dirty things is there. So you have to clean the umbilicus and bone in infant and children. Then NG feeding, if there is no any absolute contracted bleeding or something there, you have to start the NG feeding. Electrolyte and fluid, you have to change the posture is very important because the patient cannot 2 to 6 weeks not able to change their posture. So important that 1 to 2 hourly right or left posture is important. Changing frequent suctioning if needed. If not, if you put it suction is reached to the larynx, patient can die with the laryngeal response. So if when needed, frequent suctioning. Cardiorespiratory monitoring is very important because there is a autonomic involvement that can be tachyarrhythmia, tachycardia, hypertension. So it's important. Mouth, skin, bladder, and bowel care is very important. If there is a fever is there, antibiotics and sponging is very important. The tap water. Then the patient, you have to look for the patient is admitted in hospital in the separate room. Yes, you have to monitor for that. Look for the complication, like the patient can develop the aspiration pneumonia, laceration of the mouth or tongue, intramuscular hematoma, rhabdomyolysis with the myoglobin renal failure, perireal, long bone or spinal fracture, venous thrombosis, pulmonary embolism, cardiac ulceration with or without hemorrhage, paralytic ileus, decubitus ulceration, iatrogenic apnea, and cardiac arrhythmia. I told you that autonomic involvement can lead to that. So may or may not all these are any one complication can patient develop or may not develop all that complications. So you have to know about that these are the complications which patient 10 develop. Then what is the outcome or the prognosis of the patient of the tetanus? The most important factor that influence outcome is the quality of supportive care. You have to remove the exotoxin, you have to neutralize with antibodies, you have to give in the antibiotics. But important for the 2 to 6 weeks is the supportive care is very important regarding the outcome of the patient. Mortality is the highest in the very young and the very old patient. Main cause of death is the respiratory failure and respiration pneumonia. And what is the mortality rate in generalized tetanus is the 5 to 35%. And neonatal tetanus, if with the intensive, very, very good intensive care, less than 10%. So out of 10, that 9 patients can recover if there is a very intensive supportive care is there. But if there is no intensive supportive care, neonatal tetanus can 75% patient can die. So out of 10, that the 7 to 8 patients can die if there is no intensive supportive care. And cephalic tetanus also, because it is involved the head and eating and all that affected cephalic tetanus, it can be spread by generalized. So outcome of the cephalic also is not good, poor prognosis. Then there is a factors that have a good prognostic factor. Some have a poor prognostic factors in the tetanus. What are the good prognostic factor? Are prolonged incubation period, 8 to 10 days, have a good prognostic factor. There is no fever, absence of fever from the start or in between during illness. Local disease like local or cephalic. Cephalic is not a good prognosis, but local. And survival for 10 days. The patient admitted in hospital and 10 days survive, there's a chances of the good outcome. And what are the poor prognostic factors are less than 7 days between less than 7 days between the injury and the onset of the trismus, less than 3 days between trismus and onset of the generalized tetanic spasm. This is the poor prognostic factors. And fever is also a poor prognostic factor. And then prevention is important, because I told you that now the prevention is better than the cure. The disease will happen, then you see the patient needed the patient can die or needed the prolonged hospitalization. And this is the disease which is the preventable. We can prevent by the vaccines. Or we have to take the precautions when there is a deliveries, like conduct the deliveries in the hospital, train the dyes for the septic techniques, immunize the mother during the pregnancy regarding the tetanus vaccine, immunize all childbearing age females for the tetanus. Then tetanus in children, active immunize according to the EPI. There is a doses for at birth, 1.5 months, then 2.5 months, then 3.5 months for the 4 doses, and then the booster doses 5 to 10 years. When there is the age of more than 7 years, primary immunization like 3 doses you can give. First dose, then second dose after 4 to 6 weeks, 6 dose after third dose after the 6 to 12 months after the second dose. Then wound management is very important. Tetanus prophylaxis is an essential part of wound management. You have to already we have to clean the wound we discussed, and like any other circumstance, patient with unknown uncomplicated history, crush, puncture, procedure wounds, then yes, you have to give the TI. You will discuss later. There is one graph. This is important. That one, the booster, where you have to give the booster after if anybody get it the trauma. Like booster is an injured person who have complete their primary immunization series. The wound is a clean, minor, and 10 years pass. Then yes, you have to give the booster. And wound is the more serious, more than 5 years. Then you have to give the booster. This is clear from this diagram that you must, when there is a trauma, history of the trauma, you must know the state of the vaccination for the tetanus. If the unknown are less than 3 doses and the wound is clean, minor wounds is there, then this is the tetanus vaccine and this is the tetanus immunoglobulin. What you have to do, you must to take the history. It's a vaccination history like unknown are less than 3 doses, and if then you have, yes, you have to give the tetanus vaccine and no need for the tetanus immunoglobulin. What about this one? If there is a 3 or plus doses and you not give tetanus immunoglobulin, no need for tetanus vaccine. But when if there is a 10 years pass, 10 years you have passed, then you must to give. What about the all other wounds like dirty wounds? If it is battery, okay. If it is all other dirty wounds and unknown are less than 3 doses, you have to give the both. You have to must to give the tetanus vaccine and tetanus immunoglobulin in the when there is a dirty wound. And what about the 3 doses if there? Then if there is a 5 years past dirty wound, you must to give the tetanus vaccine, but no need for the tetanus immunoglobulin. So this is the very important chart regarding for the regarding the vaccinations, regarding that the wound status and vaccination, past history of vaccine, and how long that vaccination history is there. So you must to know about this one. This is a very important that 3 doses are less are more than 3 doses. The clean wound, minor wound, are the dirty or other wounds. So this is important regarding that when you have to give the tetanus or when you have to give the tetanus immunoglobulin. So thanks for you have any questions you can ask. Yes sir. Please hand here.
Raise hand and move question in line.
Okay.
स्टूडेंट हम लेके क्वेश्चन करना था माइक ऑन करें एंड क्वेश्चन करें माइक ऑन कर दीजिए.
अच्छा, anybody who want to question, please the mic on. जी जी. Hello. जी, anybody can want to question or any confusion or any suggestion or anything that you want to.
No questions, sir, but kindly share these slides on the group.
Okay. Anybody else who want to a question?
Prevention of tetanus.
Yes, prevention. I told you in detail. The prevention of tetanus is the vaccine. We have to mothers who have to if they want to prevent the neonatal tetanus, that yes, mother should be immunized. 3 doses in the pregnancy first and then later on, and then deliveries should be conducted with where there will be sterilized technique should be adopted. And then if their older child have not vaccinated or got any like wound or accident or RTA, that tetanus vaccine should be given.
Hello.
Gigi,
So isolation is needed for tetanus?
Yes, isolation is that is like if you think for the isolation for the communicable disease, no. This is isolation for not touch, no sounds, no voice, should be dark room. That is the keep the patient in a separate room, not isolation. This is look like isolation, but the word isolation is that you have to keep the patient like measles, chickenpox. This is not that one isolation. But yes, if you keep the patient with other patients, there will be sound will be there, there will be light will be there. So for these patients, you must keep in one room. That should be one single patient and should be no light, no sounds, no touching. For that one, yes.
So is there any effect of light or sound?
Yes, these all those are triggers. These all that trigger, because regarding management, I told you that when you have to keep the patient sedation, you are giving the sedation for time for limited time, like 2 to 4 weeks for to removal of that the exotoxin which is attached to the neurons. If you give the like lights, touching, and that one sounds, it will trigger this stiffness. So child will be not will be sleepy or will be not sedated and will be awake and will be stimulation and it will disturb the patient.
Thank you.
Anybody want to question, please? Any question, any suggestion regarding that? Because we know that this is the new system. We also have not familiar. You people may have some regarding suggestions. Anybody?
Sir, I want to ask about the examination system.
Examination for clinical examination.
No, I'm just asking about our final prof.
Final. Just I have seen now that letter of from that there will be a few months there will be no exam or nothing. We don't know about. If we will know, you will better know, because it will be on the site. It will be there that how will be, because still we not know about that exam. But yes, you must like exam will be in the December or January, so you must to be prepare yourself. You must daily. I said that you are now happy with your family. You are happy with the family, with the home. So now you have to must not waste the time. You must read daily 2 hours. 2 hours is very important for the reading.
Yes, the process of theory will be clear, but what about the clinical examination, like the
Yes, it
examination
is not
performed on the patient?
possible. I think we have now started this topics, and if it we will complete it, or it will be somewhere some meeting, we will give suggestion regarding the clinical. I think clinical will be not possible here. Let's see it, if it will be, then it will be for the all, from like the gynae, surgery, pediatric medicine, for the all, but it's still not under consideration for the clinical. Just this is when they started these topics. So first we have to, because we have now already time have passed, so the course is remaining there. So first we have to complete these topics, and if there will be time there, or that will be, let's see that for the clinical. Okay,
Okay, thank you so much. Thank you, sir.
thank you. Anybody, any question?
सर ये जो टेटनस का जो इंजेक्शन होता है हम फर्स्ट प्रेगनेंसी में देंगे, फिर उसके बाद सेकंड प्रेगनेंसी में भी देंगे?
No, there is a, for the in the pregnancy there is a five doses, huh? Like in pregnancy, yes, when
Yes,
that anybody, any mother know that she's pregnant, that single dose will be given. Then second after 1 month, and third after 6 months. So third dose should be given in the third trimester. So 3 doses, then 1 year and 1 year, fourth after 1 year, and fifth after 1 year. This is the pregnancy. But that for the regarding tetanus vaccine, it's not that in our mind that when there will be pregnancy, then tetanus vaccine should be given. Regarding tetanus, it's for the childbearing age. For that 20 years, 15, from the 12 to 13 years, 15 years, yes, anybody can give, can get the vaccine. 5 doses, like one, then second after 1 month, third for after 6 months, fourth after 1 year, and fifth after that 1 year. So I to suggest all you have people that you, if anybody is not vaccinated, you must to go for vaccine for tetanus. It's a very important, and later on sometime you have not time for that vaccine. So now you have to, now or later on after 1 to 2 months, you people all that for, it's not for that the patient who is coming for when there is become a pregnant and get the vaccine. In the childbearing age, like from 12 to 30 years up to 25 to 30 years, 5 doses can be given. Okay. Anybody?
thank you, sir.
Thank you. Thank you. Thanks for listening. Thank you. You are welcome, sir.
Question again.